Hi, my name is Dr. Paul Sachs, and thank you for inviting me to your conference. My topic is weight gain and antiretroviral therapy. What's going on and what should we do? So, as you know, this is potentially a difficult problem to deal with in clinical practice. And the way I'm going to approach it is as follows. I'm going to present a case, very typical of the kind of cases we're seeing here in the United States and potentially also globally. I'm going to let you know what the data show, and then I'm going to pose some questions and propose a way forward so we can learn some more. So this is a 55-year-old African-American woman who was diagnosed initially in 2008. Her initial CD4 cell count was 350, HIV RNA 33,000, and her body mass index was 31, so she was overweight already. She began TDF-FTC efavirenz, experienced no side effects and no treatment failure, and she gained 5 pounds between 2008 and 2016. However, she was diagnosed with osteopenia by DEXA scan in 2016 and was switched to TAF-FTC dolutegravir. 1 year later, she was very upset about her weight gain. She denies any change in her diet or activity level, and she is absolutely convinced that it's her new medications, and she actually requests going back on her original regimen of TDF-FTC efavirenz. So at this point, I'm going to show you graphically what her weight did. She started out as a 97 kilogram body mass index 3132, and then switched to TAF-FTC dolutegravir because of osteopenia. And 16 months after the switch, her weight is now up to 108 kilograms with a body mass index of 36. So what should we do? She, of course, should have a workup for medical causes of weight gain, checking her thyroid, etc. But if that workup is negative, which it was in this case, what are our options now? And I list several here. One would be for her to continue her current regimen, which after all is working and is better for her bone health. The other is to switch her back to TDF-FTC efavirenz. Third is to switch her to TDF-3TC doravirine, which is an option here in the United States. We could switch her to 2-drug therapy of dolutegravir lamivudine. And then there are, of course, are other options that I may not have thought of that certainly you can ask me about in the question and answer period. So this issue of weight gain in antiretroviral therapy and HIV has been on our minds for some time, especially here in the United States, where we have an obesity epidemic. And there are several papers listed here going back to 2008, but on forward, you'll see that being overweight has been part of HIV care, ironically, since initially HIV was associated with wasting. So what we know now, I've summarized in this slide. We know that when people initiate antiretroviral therapy, they gain weight, and this is true of all regimens. Some of this, no doubt, is a desirable return to health phenomenon as we correct some of the catabolic effects of untreated HIV and also the effect of untreated infections on appetite. We know that a low CD4 cell count and a high viral load at baseline are associated with the greatest weight gain. But importantly, even people with relatively normal CD4 cell counts and low viral loads may gain weight. Weight changes also occur at times with regimen switching. And so since people are suppressed and then they switch to another suppressive regimen, that implies that something is going on with ART. We also know that weight gain occurs in different magnitudes in pre-exposure prophylaxis studies in HIV-negative populations. There are demographic factors that show a high between-person variability in weight gain, and it does appear that Black females are at the greatest risk. And there also are, of course, are emerging data on individual agents and regimens, and that will be the topic of most of my presentation. So when we look at the latest data presented from the Kaiser Cohort, we see something very fascinating. Now remember, the Kaiser Cohort is a largely male cohort of individuals receiving HIV care, predominantly in California. People who start HIV therapy with normal or underweight tend to gain weight over time, as shown in the left part of this figure, and then exceed the weight of HIV-negative populations. In the center panel, we see people who are obese, and in the right, overweight, and in the right panel, we see people who are obese. What you can see in all of these situations is that weight gain occurs after initiating antiretroviral therapy and occurs at a pace steeper than people who are HIV negative. Now, the nice thing about this study is it's very large. It looks at about 5,000 people with HIV and compares them to over 50,000 people who are in these weight categories in the Kaiser cohort. However, there are some limitations. Some of the weight gain is, of course, healthy. There are unmeasured confounders that can't be taken into account. And also, as I mentioned, the study population is predominantly male. Colleagues of mine and investigators from Gilead were able to look at multiple clinical trials of people starting antiretroviral therapy over time. And we found several interesting things in these studies. We saw that integrase-based regimens were associated with greater weight gain than PI and NNRTI-based regimens. These are in prospective randomized clinical trials. That bictegravir and dolutegravir were associated with greater weight gain than elvitegravir cobicistat. And that among the NRTIs, there was a hierarchy of weight gain, with the most with tenofovir olefenamide, followed by abacavir, then tenofovir diazoproxyl fumarate, and then last is zidovudine, which is a highly toxic drug which has many gastrointestinal side effects. So since these studies were randomized, they can, of course, account for possible differences between the baseline populations and gives us a good sense of how much weight gain is going to occur based on what the regimen is. In general, the newer regimens, the ones that were better tolerated, were associated with more weight gain. And then, of course, everyone is familiar with the results from the ADVANCE study. The ADVANCE study compared dolutegravir versus efavirenz and TDF-FTC versus TAF-FTC in a 3-arm study. What was really interesting about this study was that the virologic outcomes actually turned out to be less interesting than the weight outcomes. The TAF-FTC dolutegravir, the TDF-FTC dolutegravir, and the TDF-FTC efavirenz arms all had comparable or non-inferior virologic outcomes. However, in this study done in South Africa, the TAF-FTC dolutegravir arm had the most weight gain, and in particular in women. And these data have been updated now to show that this continues out for another year, with the differences actually continuing to go up between these study arms and occurring in both women and men, although more so in women than men. Now, it doesn't only happen, as I mentioned, with initiating antiretroviral therapy. This was a first of the large observational studies to show that switching therapy is associated with weight gain. And here, investigators looked at people on stable TDF-FTC efavirenz-based regimens and then looked what happened when they were switched to an integrase-based regimen. Now, the most prominent weight gain occurred in the last of these comparisons, which is to dolutegravir, abacavir, 3TC. But all of the switches to integrase-based regimens were associated with weight gain. And remember, the control here is historical weight trajectories. So a limitation here is that this cannot account for the weight gain that occurs in many people over time. Nonetheless, it was kind of a wake-up call to all of us that these switches that we were doing were going potentially to be associated with weight gain, and not just the other consequence of switches, which is sometimes to avoid toxicity of existing regimens. These switches were also noted in this NEAT 022 study. This was a European study looking at people at excess cardiovascular risk and switching them from a PI-based regimen to a dolutegravir-based regimen. Again, switching from a PI to dolutegravir, just like switching from efavirenz to dolutegravir, was associated with significant weight gain that was then matched when the delayed switch occurred at week 48. I should note that these were individuals at high cardiovascular risk and that most of the markers of cardiovascular risk improved after the switch from boosted PI to dolutegravir. And now this study got quite a bit of attention when it was presented at AIDS 2020 this year. It took people who were on stable antiretroviral regimens in the United States and looked what happened with their weight when they switched their baseline NRTIs to TAF-based NRTIs, TAF-FTC. And you see that in the panel on the left, overall what happens is that there's a sharp increase in weight. The slope of weight gain increases. I should mention that, again, we have this obesity epidemic in the United States, and many of our patients gain weight over time. However, The trajectory of this weight gain increased, the slope of the weight increased when switching from TDF to TAF, and then after about 6 to 12 months, it then flattened out and again approached the same trajectory as seen earlier. Now, the conclusion of the investigator, who is a very experienced clinical investigator, Patty Mallon, was that this showed that there was actually weight gain directly related to TAF, tenofovir alafenamide. And indeed, you might look at these data and draw the conclusion that integrase inhibitors and TAF cause weight gain. But as I underscore here, careful, it's not so simple. And why is it not so simple? Well, let's take a look at this figure, this table right here. It looks at TDF FTC and compares it to various other regimens or to placebo and shows that TDF is consistently associated with less weight gain than comparisons. And I want to highlight two of the studies on this table in particular. Study number 1 is the APACC study, which compared TDF FTC to placebo. And you can see that the people receiving TDF FTC gained 0 kilograms versus 1 kilogram on placebo. So suggesting that something is going on with TDF as a suppressive effect. And the other study is the Gemini study. Remember, I mentioned that all studies show that when you start someone on therapy, they do gain weight, and that's shown in the Gemini studies. But look, and what you see is that TDF FTC dolutegravir is associated with less weight gain than dolutegravir 3TC. So the absence of TDF, again, is associated with increased weight gain. And the other studies listed on this table show the same thing. And now let's look at the most recent comparison. This is again a PrEP study comparing TDF FTC versus cabotegravir for pre-exposure prophylaxis. Notice the weight trajectories over time. There was significantly greater weight gain from baseline on cabotegravir versus TDF FTC. And again, the first year of treatment with TDF FTC actually had a little bit of a decrease in weight. And then after that, a slight increase, I believe, as people got used to some of the gastrointestinal side effects that can rarely be seen with TDF. So now let's switch from TDF to efavirenz. What do we know about efavirenz? Well, we've learned that there are people who metabolize efavirenz very quickly, and they have lower efavirenz levels. And there are people who metabolize it very slowly, and they have higher efavirenz level. In the ADVANCE study, which is what I mentioned before, showing so much weight gain from TAF FTC efavirenz and TDF FTC efavirenz, in the ADVANCE study, which showed so much weight gain with TAF FTC dolutegravir and TDF FTC dolutegravir versus TDF FTC efavirenz, you notice that the weight gain in the people who metabolize efavirenz very quickly is actually very similar to the dolutegravir arm. So what this implies is that people who have higher efavirenz levels, this may actually suppress weight. And if we take a look at some of the randomized clinical trials, the weight suppressive effects of TDF and efavirenz appear synergistic. And this is another one of these pharmacogenomic studies which looked at the metabolism of efavirenz, normal metabolism, intermediate metabolism, and slow metabolism. And people who are slow metabolizers of efavirenz gain the least amount of weight when it's combined with TDF, not when it's combined with abacavir. And no one has quite been able to explain this yet, and I think it has to do with these synergistic effects of these two drugs. So this brings us to several remaining key questions. Do TAF and the integrase inhibitors, especially dolutegravir and bictegravir, cause weight gain? Or do TDF and efavirenz suppress weight? Because remember, dolutegravir and bictegravir are almost always compared to regimens that are maybe weight suppressive. Or is it some combination of these effects? We just don't know yet. I think it's more the last of these, some combination. What will the weight changes be with injectable cabotegravir rilpivirine over time? Remember, this is a switch strategy that is still not approved in most countries, but it's coming soon. What about the NNRTI doravirine, which is available in some countries and not all countries? It has many of the best features of the NNRTI class without some of the side effects. So I've raised some possible studies that we can help tease this out. One would be a naive trial comparing bictegravir FTC TAF with dolutegravir 3TC with a weight endpoint. Another is a switch study with stable bictegravir FTC TAF patients randomized to continue or switch to dolutegravir lamivudine to see whether TAF is in fact somehow contributing to the weight gain independently. And the last would be a suppressed study on TAF and an integrase-based regimen randomized to TAF FTC doravirine or doravirine plus TDF 3TC, which comes as a single pill. And then my last line here is an important one to remember. There has not yet been a prospective study to date showing a significant reversal in weight gain by switching antiretroviral therapy. I want to emphasize that doravirine may not have the weight suppressive effects of efavirenz. Here it takes people who are on a stable regimen, some of them receiving efavirenz, some of them receiving other drugs, and switches them to a doravirine-based regimen immediately or a delayed switch. And you could see there is a small amount of weight gain that occurs when the doravirine substitutes for the existing regimen. Nonetheless, we are planning to do this study. It's called the Doit Study, doravirine for persons with excessive weight gain on integrase inhibitors and tenofovir alafenamide. And it will take people who are overweight or obese on a raltegravir, a dolutegravir, or a bictegravir containing regimen with TAF FTC or TAF 3TC, and who have unintentional 10% or greater weight gain over the past 3 years. And we'll randomize them to switch to doravirine TAF FTC, doravirine TDF FTC or 3TC, or a continuation of their current regimen. It's a 222-person study. Duration is 48 weeks. It would have gotten started already, but because of COVID, it was delayed, but it is about to study now. So, is modern antiretroviral therapy causing weight gain? This is an excellent editorial written by Sarah Perez from here in the United States. And she writes, the challenge for the clinician is to translate these findings into clinical practice at a time when many questions remain about the clinical implications of this weight gain. We must incorporate counseling and anticipatory guidance regarding potential weight gain when initiating ART and continue research to evaluate the mechanisms, consequences, management, and prevention of weight gain following ART initiation and switch. So to wrap up, some people with HIV will gain significant weight with ART initiation or switch. The demographic and HIV-related factors do play an important role, with advanced HIV disease and certain populations being more at risk. Integrase inhibitors and TAF are associated with weight gain, while efavirenz and TDF suppress weight, and the contribution of each of these is not yet disentangled. However, importantly, the mechanisms and management of this problem remain important research questions, and I want to invite you to invite me back to this conference sometime in the future so I can update you. Thank you very much.